Fertility control is important to the majority of the population to avoid unplanned pregnancy. And in this lecture, we're going to discuss various available methods. Effectiveness of the methods of contraception is measured by the failure rate of a method, and this is expressed as failure rate per 100 woman years. This means by how many women who get pregnant within a year of using a method. When we counsel women how to choose the best method of contraception that suits them, we need to consider the cost of the method, protection against sexual transmitted infection, safety and side effects, comfort and ease of use, and therefore compliance, reversibility, and fertility plan. Most methods of contraception are safe for most women, and the United Kingdom medical eligibility criteria is a definitive reference guide concerning all methods of contraception, indicating which women can safely use which of the following methods: natural family planning, barrier methods, combined hormonal methods, progestogen only, injectable contraception, subdermal implants, and intrauterine methods. The United Kingdom medical eligibility criteria is the same as the WHO medical eligibility criteria, which includes 4 categories. The first one, where a condition for which there is no restriction for the use of the contraception methods, no contraindications, no restrictions. Category 2, where advantages outweigh the risks. Category 3, where there is relative contraindication, so where is a theoretical or proven risks that outweigh advantages. While category 4 is absolute contraindication, where the method is unacceptable to be used. Natural family planning or fertility awareness contraception involve avoidance of intercourse during the fertile phase of the menstrual cycle. The first method, cycle or rhythm method, calendar method, طريقة العد. This is based on the length of the menstrual cycle and the lifespan of the sperm in the female genital tract of around 5 to 7 days. Women with regular cycles can calculate the ovulation day and avoid intercourse around that time. Temperature method relies on a biological indicator of ovulation. We instruct women to measure their temperature daily in the morning when they wake up, and preferably at the same time. Whenever they have rise in temperature for 3 days in a row compared to the previous 6 days, we tell them that they are not fertile at that time. The rise in temperature is very small, of around 0.2 degrees centigrade, and this can be explained by progesterone, which is a thermogenic hormone. The Billings method is based on the changes in quantity and consistency of the cervical mucus, physiological changes as we discussed in the menstrual cycle. Lactational amenorrhea falls in this category, although this can only be used after childbirth. The effectiveness of these methods can be increased when they are combined. Mode of action, advantages and disadvantages are apparent from the idea of avoiding intercourse around the fertile phase. The exact mechanism of lactational amenorrhea is poorly understood. It could be due to the inhibition of normal pulsatile LH, and therefore this leads to an ovulation. This is an effective method if it is used in women who are exclusively and fully breastfeeding and in the first 6 months, and these women are amenorrheic. There are no restrictions, no medical conditions where lactational amenorrhea is contraindicated. Whenever women start to wean their babies, or whenever they introduce supplements, or they're not fully breastfeeding day and night, and after 6 months, or whenever they start menstruating, this method will not be efficient on its own. So for this method to be efficient, the breastfeeding should be exclusive in the first 6 months, and women should have no period, should be amenorrheic. Barrier methods include male and female condoms, in addition to diaphragm, cervical cap, sponge, with the use of spermicides. The effectiveness of these methods depend on the quality and consistency of use. The failure rate in general ranges from 4 to 20 per 100 woman years. You note the wide range of failure rate, and from 4 to 20, and this is due to this can be explained by the perfect use failure rate and the typical use failure rate. This is a user-dependent method, and this is why user-dependent methods, if they're not used perfectly, the failure rate increases. Mode of action is clear, preventing sperm reaching the female upper genital tract, and they are mechanical method is recommended whenever hormonal contraception is contraindicated, or when short-term contraception is required, and it offers protection against sexual transmitted infections. Of course, there are advantages and disadvantages of mechanical contraception. Remember, with the diaphragms, the first insertion should be in the clinic, done by the health provider or the doctor, and then this can be changed by the woman herself. If she gains weight of 4 or more kilograms, the size of the diaphragm needs to be changed. Combined hormonal contraception include estrogen and progesterone preparation, and they can be in the forms of pills, patches, or vaginal ring. The mode of action of combined hormonal contraception is inhibition of ovulation, changes of the cervical and vaginal mucus, and therefore inhibiting transport of the sperms, changes in the endometrium that it becomes atrophic and therefore non-receptive. There are advantages for using the combined hormonal contraception. This is a reliable method, reversible, user-dependent. This means the woman can stop using the method at any time, and it is independent of intercourse in addition to non-contraceptive benefits. There are also disadvantages, minor side effects, increased risk of venous thromboembolism, and this is usually in the first year of using the combined hormonal contraception. Increased risk of arterial disease if there is a risk factor for that, and there are interactions with some medications as anti-epileptic and anti-TB medications, where the absorption of the combined hormonal contraception will be reduced. Again, the absorption will be reduced if if there is vomiting and diarrhea, and of course, if missed pills, then there will be a failure of the method. The effectiveness of combined oral contraceptive pills is measured by the failure rate. The failure rate ranges between 0.2 to 8 per 100 women year, and this depends on the reliability of using the method. This wide range, as we said earlier, depends on the perfect and typical use failure rate. Usually, if the pills are used in the correct way, perfect way, the failure rate is really low. The combined pills can be monophasic, that is, there are tablets in the sachet with a fixed dose of estrogen and progesterone all through the packet. Variable dose, the phasic ones can be bi or triphasic, and these were made trying to mimic the natural cycles, the changes in estrogen and progesterone during the cycle. With combined pills, the first 7 tablets are very important because they are the ones to inhibit ovulation, while the other 14 they are to maintain anovulation. In most of the packets, there are 21 tablets in a sachet and 7-day pill-free interval. Some combined oral contraceptive pills have 28 tablets, but the last 7 tablets are placebo, only iron supplements. Combined oral contraceptive pills are composed of estrogen and a progestogen. In the 1961, the combined oral contraceptive pills, which were marketed, contained relatively high dose of estrogen and progestogen, and these were associated with high risk of venous thromboembolism and other side effects as nausea and breast tenderness. And the risks have been reduced by the development of combined pills with lower doses of estrogen and the modification of progestogens. Estrogen can be either or mainly ethinyl estradiol in most of the pills, estradiol valerate in Clara tablets, and estradiol in another type of pills. The main estrogen which is available in pills is ethinyl estradiol. It was in the past, the dose was at 50 micrograms, that was reduced to 35 micrograms, and in the newer generation we have 20 micrograms of ethinyl estradiol. Progesterone itself cannot be used in combined oral contraceptive pills because of its rapid metabolism in the liver, and this is why we use synthetic progestogens that were produced from progesterone or testosterone. The earliest generations were levonorgestrel and norethindrone were derived from testosterone, while the latter ones were derived from progesterone and spironolactone. You can see these progestogens colored into generations: first, second, third, and fourth drospirenone, while cyproterone acetate counted as a fourth generation in addition to drospirenone by some references, while others counted as not yet classified. Cyproterone acetate has anti-androgenic activity, and this is why it is used in the management of androgenic symptoms as acne and hirsutism, and in combination with ethinyl estradiol, it is a combined contraception. Whenever you have a woman presenting with hirsutism and acne, as in cases of polycystic ovary syndrome, and they require contraception at the same time, then the procedure of choice will be Dayan. Dayan is a combination of ethinyl estradiol and cyproterone acetate. Cyproterone acetate is available on its own as a medication called Androcure, and we use it in the management of hirsutism, moderate to severe, in combination with Dayan. The newest generations of the pills are less androgenic, and they have less problems with water retention. We have benefits, as we said, advantages of the combined pills. One of them is non-contraceptive benefits. The combined pills decrease menstrual disorders as menorrhagia. Combined pills reduce blood loss, manage irregular bleeding, irregular cycles by 50%. And this is why we take a menstrual history for women requesting a method of contraception. If they have history of menorrhagia and irregular cycles, then combined pills will be the procedure of choice. Also, they reduce dysmenorrhea by 40%. Pills can also be used in the management of premenstrual disorders, and in these situations, Yaz tablets were used because they contain 24 pills, trying to mimic the menstrual cycle as much as possible. There is also reduction in functional ovarian cysts, reduction in benign ovarian tumors and breast disease, reduction in pelvic inflammatory disease. Also, there is 50% reduction in endometrial and ovarian cancer, and this continues for 15 years after stopping the combined pills. There is also reduction in colorectal cancer. Combined pills were found to be protective against rheumatoid arthritis, thyroid disease, and duodenal ulcer. Major side effects include venous thromboembolism. The highest risk for thrombosis will be in the first year of using combined hormonal contraception. Just to tell you that the incidence of thrombosis in non-pill users is 5 per 100,000 women year. For women using second generation combined pills, the risk is 15 per 100,000, third generation 25 per 100,000, while pregnant women have a 60 per 100,000 risk of thrombosis. Remember, pregnancy itself is a thrombogenic situation, and those who are against the pills because, and especially the newest generations, because slightly increased risk of thrombosis, need to remember that pregnancy itself has a higher risk of thrombosis compared to the newest generations of combined pills. MI and stroke increase with or in the presence of risk factors as smoking and hypertension. Migraine actually is very important, and I've mentioned it here because it is a risk of, if it is present and we use the pills, the risk of ischemic stroke increases. Remember, whenever there is a history of migraine with aura, combined hormonal contraception is absolutely contraindicated at any age. Before the age of 35, if there is migraine without aura, then the combined hormonal contraception is relatively contraindicated. After the age of 35, migraine with or without aura is a contraindication for the use of combined hormonal contraception. Breast cancer slightly increases with combined pills. You can note that the non-pill users have a 10 per thousand risk, and this increases to 11 per thousand uh, for those who use the pills, and this continues for 10 years after discontinuing the pills, and then this goes back to the background risk. There is also slight increase in cervical cancer and slight increase in benign and malignant tumors of the liver. Side effects of the combined pills can be either due to the estrogenic or progestogenic component. Sometimes both estrogen and progestogen can cause the same side effect. Contraindications of the combined hormonal contraception. Please go back to the United Kingdom medical eligibility criteria to check the categories 1, 2, 3, and 4. This is a quick summary for you to see absolute and relative contraindications to combined oral contraceptive pills, category 3 and 4 of the United Kingdom medical eligibility criteria. This is a continuation of the list of absolute and relative contraindications. Whenever you have a woman presenting to the clinic requesting combined hormonal contraception, how to assist this lady? Always start by taking a history. Of course, you start by her age, medical illnesses, past contraceptive use, if she used the same method before, what method she used before, if she was comfortable with the method, or if she got pregnant while using the method, past obstetric history. Menstrual history is very important, because if she says that she has heavy periods, dysmenorrhea, then probably combined oral contraceptive pills will be the method of choice. If she complains of hirsutism, acne, and she wants contraception, then you can give her Dayan as the combined pill of choice. Ask about medications. If she's using any medications, especially anti-TB and anti-epileptic medications, history of migraine with or without aura, epilepsy, risk factors for thromboembolic disease, sexual history, and check the woman's risk for sexual transmitted infection, family history that increase the woman's risk of thromboembolic disease, and very important, most importantly, smoking. Physical exam, check the blood pressure and body mass index. You counsel the woman and you decide to give her combined hormonal contraception. When to start? If she's menstruating for the first time, it is preferable to start in the first 5 days of the period, and some manufacturers specify the first day of the menstrual cycle to start the combined pills. If she's amenorrheic, as breastfeeding women, what should they do? Should they wait for a period before starting the combined pill? Actually, no. If you know that they're not pregnant, first of all, you need to make sure they did not have any unprotected intercourse, then they can use the combined pills. Probably they may need backup method for the first 7 pills, because they are the ones to induce an ovulation. Post-delivery, postpartum, they can be used 6 weeks post-delivery. We do not start combined pills before that. Why? Because Estrogen increases the risk of thrombosis, and pregnancy itself is thrombogenic with increased risk of thrombosis. So, combined pills are not used before 6 weeks after delivery. Miscarriage, if miscarriage occurs, then combined pills can be used immediately after a miscarriage. Some prefer to wait for 2 weeks, but usually you don't need to wait after a miscarriage. Start combined pills immediately. What if the lady forgets to take her pill? What if you're called uh, and asked about the missing pill? When we manage the issue of missed pill, we need to think of how to continue the contraceptive effect of the method and if emergency contraception is required. If one pill is missed, then the lady takes this pill as soon as possible in addition to the required one and continues the method without the need for emergency contraception. If she misses two or more, then to continue the method, we instruct her to take the most recent pill as soon as possible and the rest of the pills as usual. But she needs to use condom or abstain for 7 days. So a backup method is needed. This is how to continue the contraceptive effect of the method. Do we need emergency contraception? In the first 7 days, yes, we need emergency contraception if unprotected sexual intercourse occurred in the pill-free interval or the first week of the pills. In the second 7 days, between with the pills 8 to 14, no emergency contraception is required if the first 7 pills were taken. In the third week, pills 15 to 21, we do not need emergency contraception, but what we need is to omit the pill-free interval by finishing the pill in the current pack and starting a new one the second day. Remember, I said combined pills are usually composed of 21 pills and a 7-day pill-free interval. The first 7 tablets are required to induce anovulation or to inhibit ovulation, and the other 14 are to maintain anovulation. And this is why if two pills are missed with the first 7 pills, we need emergency contraception. If unprotected sexual intercourse occurred, the second 7 pills, we do not need emergency contraception. With the third, omit the pill-free interval, finish the pack, the current one, and start a new one the next day without pill-free interval. You bring the lady 3 months after starting the pills for follow-up to check her blood pressure, check for changes in risk factors, and if this lady is suitable to continue using the method or not, give further instructions and manage problems if they arise. Breakthrough bleeding is the bleeding that occurs while women start using the combined pills, and it is a copy of intermenstrual bleeding. It occurs usually in the first few months of using the combined pills, usually the first 3 months, and then it stops. It can occur due to default when a woman misses 2 or more of her pills, sexual transmitted infection, chlamydia, if she's pregnant, if she takes any medications, or if there is diarrhea and vomiting that affect the absorption of the pills and therefore their effectiveness. And of course, in low dose pills, whenever we talk about low dose pills, we're talking about the estrogen dose. So, to one of the options to manage breakthrough bleeding is to change the pills to a higher dose estrogen pills. If a woman calls you or rings you up to say that she has breakthrough bleeding, don't immediately reassure her that this is because she's new to the pills and this will settle with time. Please make sure you rule out pregnancy and she's not at risk of sexual transmitted infection. If you rule this out and if after 3 months she does not improve, this means that you need to change the pills to another preparation with higher estrogen. Progestogen-only contraception include progestogen-only pill, injectables, implants, and intrauterine system Mirena. Progesterone-only pills contain progestogens only, and they are called by some as mini pills أو حبوب الرضاعة. The older first-generation progestogen-only pill do not prevent ovulation and have to be taken within 3 hours of the same time every day, while the newer desogestrel-only pill, Cerazette, where there is around 97% inhibition of ovulation, there is a longer window for administration of around 12 hours. The other effect is changes in the cervical mucus to prevent sperm penetration. The failure rate for progestogen-only pills is low, ranging between 0.3 to 0.8 per 100 women year. It is a safe method for women after the age of 40 because of decrease in the fertility rate, and there is no need to increase the dose with increasing weight as this was in the past. We used to increase the dose for obese women. Progestogen-only pills are taken daily at the same time, and there is no pill-free interval as compared to combined oral contraceptive pills where there is a 7-day pill-free interval. With progestogen-only pills, no pill-free interval. The lady should continue taking the pills every day at the same time. Injectable progestogens include Depo-Provera, which can be given every 12 weeks, and norethistron enanthate that is given 8 weekly. And injections act by inhibiting ovulation in addition to changes in the cervical mucus to prevent sperm penetration and some changes in the endometrium. The failure rate of Depo-Provera is low, and the main disadvantage is the delayed return of fertility of up to 18 months. It is also linked to weight gain, and this is why it's not advisable to give it to obese women. It is also associated with a small reversible reduction in bone mineral density as a result of the hypoestrogenism with long-term treatment, and this is why there should be caution with the long-term use in those with additional risk factors for osteoporosis and the extremes of the reproductive age. Implanon, progestogen-only implant. This is a 4 centimeter flexible single rod containing 68 millimeter etonorgestrel which is released slowly into the systemic circulation following subdermal implantation in the upper arm. We can keep it in for 3 years. It acts by inhibition of ovulation in addition to changes of the cervical mucus and endometrium. The main side effect of Implanon, as all progesterone-only methods, is bleeding problems, changes in the bleeding pattern. And for Implanon, there's a problem of weight gain, the same as Depo-Provera. It has to be inserted by a healthcare provider, and sometimes there could be complications with its removal, difficulty to remove it if it is deeply implanted. All progestogen-only methods can be used whenever estrogen is not acceptable because it is either contraindicated or because of its side effects. With Depo-Provera, this can be used while awaiting sterilization or vasectomy to be effective, and because of its non-contraceptive benefits, and the same applies to Mirena intrauterine system, these both Depo-Provera and Mirena can be used in patients with menorrhagia, dysmenorrhea, and endometriosis. All progestogen-only methods are safe during lactation. For contraindications of progestogen-only methods, please refer back to the United Kingdom medical eligibility criteria. Long-acting reversible contraception, LARC, include hormonal and non-hormonal methods. Long-acting reversible contraception when the method is used less than once in a cycle. Intrauterine contraceptive device, copper IUCD, coil or loop. The standard T-shaped IUCD is made of a T-shaped plastic covered by copper. The surface area of copper is different between different types. The standard one has a 380 square millimeters of copper, and this can be left in for 10 years. It has a thread at the bottom for the IUCD to be followed later on that it is still in place and to remove it easily. Other copper IUCDs may have different amounts of copper. Nova T can be kept in for 5 years, and this one has copper wire with a silver core. Levonorgestrel Mirena intrauterine system can be kept for 5 years if it is used as a method of contraception, but if it is used for endometrial protection, hormone replacement therapy, then we can keep it in for 4 years only. The failure rate of copper IUCD is very low, and even lower for Mirena, the failure rate of around 0.200 women year. Mode of action for intrauterine contraceptive device is by inhibiting fertilization by direct toxicity, anti-implantation inflammatory reaction within the endometrium, and copper in the cervical mucus inhibits sperm penetration. These are for the intrauterine contraceptive device, copper IUCD. While for the intrauterine system, levonorgestrel intrauterine system Mirena mainly has an effect on the endometrium and cervical mucus. Mirena or Mirena intrauterine system IUS was marketed initially as a medication, and this is why we say intrauterine system. It is the first line management of heavy menstrual bleeding, menorrhagia. You can see Mirena has a T shape, and it is made of polyethylene frame, which with a hormonal reserve of 52 milligrams of levonorgestrel, and this releases daily levonorgestrel at a rate of 20 micrograms per day for 5 years, and this is reduced later to 11 micrograms per day. This is why we keep Mirena for 5 years as a method of contraception, but for 4 years if it is used as hormonal replacement therapy. To insert the IUCD, you need to check the risk for sexual transmitted infections. So take a sexual history. If at risk, do screening for chlamydia infections. If you don't have the result by the time you're going to insert the IUCD, this is when you need to give prophylactic antibiotics. It can be inserted if the lady is menstruating immediately after the period. Let's say the period is for 5 days, you can insert it on the 5th or 6th day when the bleeding is minimal, to make sure that this lady is not pregnant and the cervix is slightly open, so the procedure will be easier. If the lady is amenorrheic, then you can insert the IUCD at any time, provided the lady did not have unprotected intercourse. If after delivery, usually we wait 4 to 6 weeks after the delivery, regardless of the mode, vaginal or cesarean, to insert IUCD. This is because of the risk of perforation. Although in some studies, IUCD was inserted immediately after delivery, provided or cautiously keeping in mind the risk of perforation. There was an Indian study where an IUCD inserted immediately at the time of the delivery, and the outcome of that study that there was no increase in the risk of expulsion of the IUCD if it was inserted at the time of delivery. Once you insert the IUCD, you need to bring the lady again after 4 to 6 weeks of insertion or after the first period, to make sure that the IUCD is still there, did not is in situ in the correct place, no descent with the IUCD, and or there's no expulsion with the clots in a heavy period. You bring the patient back or the lady back, do a speculum, check that the thread is seen, or do an ultrasound to check that the IUCD is still in place. To remove the IUCD, you can remove it at any time if the lady wants to remove the IUCD because she wants to become pregnant. If she wants to remove the IUCD but she does not want to become pregnant, then you need to make sure that she did not have intercourse around the time of ovulation, if this is the time you're removing the IUCD. If you're changing one copper IUCD to another one, you can change it on the same day, regardless of the history of intercourse. The same does not apply to Mirena, because IUCD is a method of emergency, it is licensed as a method of emergency contraception, while Mirena is not. Contraindications. Possible risks with IUCD, IUS insertions. First of all, expulsion. Expulsion, that means when the IUCD comes out, the chances are 1 in 20 in the first 3 months. And usually it comes out with a heavy menstruation, and this is why I told you we need to follow the lady up 4 to 6 weeks after IUCD insertion. Pelvic inflammatory disease, increases by 6 times in the first 3 weeks of insertion, but then the overall risk is low unless there's a risk of sexual transmitted infection. And after 3 weeks, the risk of PID is the same between IUCD wearers and non-wearers. Perforation at a risk of 2 per thousand most commonly occurs at the time of insertion. If perforation is suspected at the time of insertion, and usually this occurs with a sound during the procedure, abort the procedure and don't insert the IUCD. If perforation is suspected after the insertion of IUCD, then we admit the patient for laparoscopic removal of the IUCD. If when she presents for follow-up, you discover perforation, then you arrange for elective laparoscopy to remove the IUCD. Ectopic pregnancy, the chances are really low. The risk of pregnancy is reduced by the use of IUCD, but if pregnancy occurs, then you have to rule out ectopic pregnancy. So overall, ectopic pregnancy does not increase with IUCDs, but if pregnancy occurs, you have to rule out ectopic pregnancy. There could be change in the bleeding pattern and dysmenorrhea. Cycles may become heavier with dysmenorrhea, menstrual cramps. Vasovagal attack may occur at the time of insertion. That's all. It does not occur after that, but at the time of the procedure. And lost thread is another risk. Pregnancy, if there is failure of the procedure, and I said the failure rate is really low for the IUCD and even lower for the intrauterine system Mirena. The failure rate for the Mirena is around 0.2%, 1 in 200. When a lady presents for follow-up, as I said, you do a speculum exam to check the thread of the IUCD. If you don't see the thread, you need to think, why can't I see the thread? Is it because of expulsion? Is this IUCD still in, or was it lost out with the menstruation? Is there perforation, pregnancy, or a short thread? When we insert the IUCD, we leave around 2 centimeters of the thread coming through the cervix, and this is needed for follow-up and to remove the IUCD. If you can't see the thread, then you have differential diagnosis of expulsion, perforation, pregnancy, or short thread. You do an ultrasound. Copper IUCD is clearly apparent by or clearly seen by an ultrasound, abdominal and transvaginal, while with Mirena IUCD you need experience to see it because it is not the same appearance by scan as copper IUCD. If you do an ultrasound scan and you don't see the IUCD, this means that there is perforation. You do an X-ray. With the X-ray, abdominal X-ray, copper IUCD, copper is radio opaque. You can see it. If you can't see it, this means that the IUCD, copper IUCD, is not there anymore. While with Mirena, it's not radio opaque. You may need to do a CT scan to see if the Mirena is still in or not. What if the lady becomes pregnant with intrauterine contraceptive device? As I said, first of all, rule out ectopic pregnancy. Then, if before 12 weeks you see the lady, remove the IUCD if you can see the thread. If you can see it, pull the IUCD out. Of course, you need to counsel the patient before that about the increased risk of miscarriage with removing the IUCD. I know pregnancy on top of IUCD is unplanned, but it could be wanted. And this is why you need to explain the slight risk of miscarriage while removing this IUCD. If you keep the IUCD in, there is increased risk of spontaneous second trimester miscarriage, preterm delivery, and infection. With Mirena, side effects also include the hormonal side effects of levonorgestrel. As I said, there's a pool of or hormonal reserve of levonorgestrel that is released locally, and this is why there could be hormonal side effects of progestogen. Changes in the bleeding pattern is the most common side effect. This can be either amenorrhea or spotting. Irregular bleeding is usually for the first 3 to 6 months, but by all means, this bleeding will be less than before if the lady has heavy bleeding. And 1 in 3 women may become amenorrheic 1 year after using the Mirena. This is an advantage for some women, but a disadvantage for others where they want to see their cycle regularly. The most common cause for removing Mirena is the blackish discharge, which becomes annoying for women. Other side effects of IUS are the progestogen side effect of headache, mood changes, acne, breast tenderness, reduced libido, and increased risk of ovarian cysts. This is the same as progesterone-only pills, and we're going again to mention this side effect with progestogen injections and implants. For the contraindications of intrauterine contraceptive device, please go back to the United Kingdom medical eligibility criteria. For category 4 and 3, a backup plan is required when there is unplanned, unprotected intercourse, or if there is accident to the condom, or if there are missed pills, we need plan B. Emergency contraception. Emergency contraception can be either hormonal or non-hormonal. Hormonal include progestogen only, Livonil 1500, which contains levonorgestrel. This should be taken as soon as possible after unprotected sexual intercourse and up to 72 hours. It can be taken a bit later, up to 120 hours, but with limited evidence of efficacy. Whenever you give this tablet to a woman, you have to explain the license of the medication for medical litigation issues. The advantage about Livonil that it can be taken more than once in a cycle if emergency contraception is required, but double dose is required if the woman is using liver enzyme inducing medications. Livonil acts by causing changes in the cervical mucus and therefore impair sperm transport, but it may inhibit ovulation depending on the time of the period when it was given. Ulipristal acetate, ILA-1, is another hormonal emergency contraception. It is a 30 milligram tablet, selective progesterone receptor modulator, and it can be taken up to 120 hours of unprotected sexual intercourse. It is licensed for that. Same efficacy as Livonil, but we cannot repeat the dose if required in the same cycle. Copper IUCD is the non-hormonal emergency contraceptive method. It can be inserted up to 5 days of the first episode of unprotected sexual intercourse and up to 5 days of the estimated day of ovulation. It is effective immediately, and the advantage is that it can be kept in and used as a long-term and reversible method of contraception. The failure rate is low, but screening for sexual transmitted infections may be required, and with appropriate prophylactic antibiotics against chlamydia. Contraindications are the same as contraindications for copper IUCDs in general. If 1,000 women have a single act of unprotected intercourse, 80 women would be pregnant if no emergency contraception was taken. This is compared to 10 women who take progestogen-only emergency contraception, and only 1 woman would be pregnant if a copper IUCD was inserted. So a copper IUCD is the best emergency contraceptive method. Mirena IUS, the hormonal IUS, is not licensed as a method of emergency contraception. Side effects of progestogen-only emergency contraception include vomiting, and if this happens within 1 to 2 hours of taking the dose, then this should be repeated. The timing of the next menses can be difficult to tell, and this is why we tell women usually to observe their next cycle. We don't know when the next one will be. If there is a failure of the method and pregnancy occurs, then we have to rule out ectopic pregnancy. If the pregnancy is intrauterine, reassure the woman that this medication is not teratogenic and it is not an indication for termination on this basis. Sterilization is a permanent method of contraception. This is a irreversible method, and this is why great care has to be taken to ensure that the couples are counseled appropriately and that they have fully understood the implications of the procedure. Full explanation should be given to couples with detailed written consent obtained before doing the procedure. Female sterilization involves occlusion of the tubes, fallopian tubes, and the lifetime failure rate is 1 in 200. The failure rate may vary with age of sterilization and with the method of tubal occlusion. The methods that we use include laparoscopy, hysteroscopy. It can be done at the time of the cesarean section, and also laparotomy may be used if laparoscopy is not possible. It is assumed that failure rate at the time of cesarean section is slightly higher compared to non-pregnant women. Sterilization may fail during the initial procedure or later due to recanalization of the fallopian tube. Early failure could be due to the fact that the lady was pregnant at the time of sterilization, and this highlights the importance of taking adequate history of the menstrual cycle and making sure no unprotected intercourse occurred before sterilization, and pregnancy test arranged before the procedure. For hysteroscopic sterilization, a hysterosalpingogram should be done after 3 months to confirm that both tubes have been occluded. Male sterilization or vasectomy involves occlusion of bilateral vas deferens. Failure rate is, or lifetime failure rate is 1 in 2,000, which is much less than the failure rate of the female sterilization. This is a simple procedure, can be done under local anesthesia, no scalpel technique, but you need to remember that sterilization with this procedure is not immediate. The couple need to continue on whatever method of contraception they were using before sterilization till we have 2 samples of seminal fluid confirming azoospermia. We usually do the first sample after 6 weeks of the procedure and 12 weeks later. You can see different methods of sterilization. Laparoscopic Filshie clip is very famous. We have the rubber rings. We can use cauterization. It is important to make sure there's no place for recanalization of the tube, and the hysteroscopic procedure where both tubes, a material is injected in both tubes for fibrosis to occur. Remember, if this was the method, then we need a hysterosalpingogram after 3 months to confirm occlusion of both tubes. Fertility declines after the age of 40. Just to remind you that there is no contraceptive method that is contraindicated by age on its own. This slide summarizes your counseling points when you take a history from a woman who wants a method of contraception. Remember, when we say counseling, counseling means, first of all, to take a history from the woman to know what are her wishes, what medical history, what are the possible contraindication for whatever method that you're going to offer. Then you give options. What are the available methods that you have? You may explain mechanism of action for the method, possible side effects, how to use the method, follow up plan, what to do if whatever side happens occurs, whom to contact, and what else? What about fertility plan, fertility in the future? This is what we mean by counseling. We may ask you to counsel a woman or to specifically talk about certain part. We may say take a relevant history or explain to Mrs. X how this method acts, or explain the non-contraceptive benefits, explain the contraceptive or the way that you use this method. Keep all of these things points in mind.